Welcome to Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Winn. We will also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond. Today, we're speaking with Dr. Elizabeth Morris. She's professor and chair for the Department of Radiology and also a pioneer in high-risk breast cancer screening.
Also joining us today is Dr. Megan Daly, a professor of clinical radiation oncology and the associate director for clinical research at the Cancer Center. Thanks for joining us today.
Well, today is a bit of a unique topic because one of our experts is also a cancer patient, and that happens sometimes. So tell us what that experience was like.
So it was fairly surreal because I had accepted the job here at UC Davis, and my former place of employment was at a cancer center, Memorial Sloan Kettering Cancer Center. And I was standing in my bedroom in my apartment, and the movers were coming when I got a text from my breast surgeon saying that they had discovered a breast cancer on the biopsy, which was completely a surprise because I had had surgery for a reduction, so it was for a benign reason. So I was in the middle of moving to UC Davis and leaving New York, and I had this cancer diagnosis. So that obviously put me into a panic because I was supposed to start working in 2 weeks. So I was then had surgery in New York, but I was so grateful to be coming to UC Davis and to the Comprehensive Cancer Center here and to Dr. Megan Daly because I knew she was a huge expert in radiation oncology because I needed to receive radiation. And so I felt very secure and safe in coming to Davis. And so I arrived here and immediately connected with her and got my radiation therapy done out here.
What did you learn from what makes practicing medicine different for you now?
The whole patient experience definitely resonates with me. Waiting for results, waiting for appointments. I think with breast cancer, it's so important to be timely and not have people wait for information, because information is really key, because once you have that information, you're able to know what the plan is. And so not knowing what the plan for your treatment is can be very anxiety-provoking, very scary. But once you have a plan and you know what's going to happen, that can really be incredibly helpful.
And then in terms of staying on top of screenings and doing the most you can as a woman to detect breast cancer early when it's most treatable, you have long advocated for women with dense breasts and getting MRIs versus just the traditional mammography done. Can you talk about that?
Absolutely. It's kind of ironic because I have dedicated my life to early detection and picking up cancer at its earliest stage with alternative techniques other than mammography. So mammograms are fantastic. They have decreased. To me, they're one of the biggest advances in this last few decades for saving lives. But they are limited, and they're very limited in women with dense breasts. So that means we need to look at other alternatives, and some places they use screening ultrasound to supplement the mammogram. For example, on the East Coast, screening ultrasound is a lot more prevalent than here on the West Coast. And and also contrast-based techniques, which I'm very interested in and promoting, can pick up very early breast cancers, and they can pick up cancers that are 4 millimeters in size, which a mammogram sometimes cannot pick up, especially in dense breasts. We have two contrast-based techniques that are available and that is with MRI. And we have a newer technique, which we are just getting here at UC Davis, and that's contrast mammography. And both of those tests can pick up smaller, earlier stage breast cancers.
I visited the new machine in the Rockland Clinic. It was very impressive, and I know that there'll be additional machines going in soon in Sacramento and most likely in Folsom. So accessibility is big, and it sounds like you're bringing the latest and greatest to UC Davis Health, and we're so glad your health is back on track and you're doing very well and leading the Department of Radiology with a lot of new technology.
Well, we hope to bring it, to the women of Northern California so that they can have access to the latest techniques, and especially for those who have a high risk in their family, and also for those women who have a mammogram that may not be able to detect, may have limitations in detection of breast cancer.
Well, Dr. Morris, what was it like becoming the patient rather than the physician?
So it was strange. It was almost as though you become a different person in a sense, but it was reassuring in a way because this was my specialty and I really understood what the pathology report meant as far as aggressiveness of the tumor and as far as prognosis. So I think having that inside information was very helpful. And I had a very small tumor and it was not very aggressive, so I was reassured that surgery and radiation would be enough for treatment. I was lucky that it was very early, so I was able to avoid chemotherapy. So I knew that already in my mind. So that's why I was talking about having the information can be very helpful. And so having that sort of insider information was very helpful to me. But it really made me appreciate all of the steps that our patients have to go through. Particularly, scheduling appointments, surgeries, making sure that you can get to work after your radiation treatments and things like that. And I have to tell you, the Cancer Center is very, very helpful in making that happen. And so I'm very, very grateful to have been treated here.
Dr. Daly, kind of the same question, but flipped. How is it having a colleague as a patient?
Well, I've certainly had other physicians as patients many times, but in particular, having a patient who was an expert in their own specific cancer does mean that you can have a different level of informed consent discussion and a different level of discussion around treatment options in general. I would, in the end, recommend the same treatments to any of my patients, regardless of who they are. But certainly with Liz, we were able to have a higher level conversation about the various options, and I was able to use more technical language rather than layperson language and be comfortable that she obviously understood what I was discussing. And you can't do that most of the time with patients who are not physicians or even patients who are physicians in an unrelated field.
So it was more of a two-way collaborative approach to her treatment, probably.
Yeah, I would consider it collaborative.
To detect breast cancer, you have mentioned, a couple of different screening options. Are there current guidelines that lay out just like a blanket approach, or do we have differing recommendations based on different types of patients?
Well, currently we have population health-based recommendations, which is we have recommendations that all women starting at the age of 40 should be screened with mammography. And here at UC Davis, we recommend that they be screened every year with a mammogram. Now, we are, I think, evolving, and it's not here yet, but we're evolving into a more personalized approach to cancer screening. And that involves with patients' history and their possibly genetics, and we have new AI tools that are coming out that show that you can actually predict risk of subsequent breast cancer from the mammogram itself. So these are really exciting developments, and I think will lead to more of a personalized recommendations. For example, maybe you don't need to go every year for a screening examination, and you're not at higher risk for breast cancer in the next 5 years or so. So you may not have to go go every year. You may have to go every 2 years or 3 years or 4 years or something like that in the future. So I think these are really promising techniques. Now, if you're high risk, and that is if you have any genes for breast cancer, that's the BRCA1, BRCA2, and PTEN, and there's a whole host of genes that elevate your risk for developing breast cancer. We recommend that you have a breast MRI every year, as well as your mammogram.
And getting back to the topic of women with dense breast tissue, and I think that's 50% of women out there. Explain a little more about why dense breast tissue can lead to a higher risk of breast cancer and the screening guidelines in particular for that group.
So having dense breasts, and as you said, it's a normal situation, breast density, but 50% of women have dense breasts, and it's sort of a double whammy. It means that it makes it harder to pick up breast cancer because the density of the breast tissue, the normal breast tissue, masks the cancer that has the same density from detection. So it's harder to detect the cancers, so they may be detected at a later stage. The second, the double whammy, is that you do have a slight elevated risk of breast cancer if you have dense breasts. So that's why many people recommend having supplemental screening to dense breasts. There's many states that have passed legislation to say that if you have dense breasts, you should have a screening ultrasound or a screening MRI examination.
Every year, or say every
year?
Few years? What's every year? MRI. Okay.
Yeah, that's why I think the personalized approach is going to be hopefully decrease the need to do that,
As a man, I'm going to ask an ignorant question, but I'm hoping that maybe somebody else might have this question also. How does a person know that they have dense breast tissue versus not dense breast tissue?
That's a great question, because yes, okay, so one would expect that you could tell by physical examination, but you can't. It is only on mammography that you can tell. So you have to have had a mammogram to know if you have dense breasts or not. And it has really very little relation to size or how they feel.
And now, especially in California, I believe, those results must be communicated to patients, whether or not they have dense breasts, correct?
Yeah, there's a group called Are You Dense? And they have been very strong politically.
That's a catchy name.
Yeah, are you like dense in your head? But they've been very strong politically and have ushered in state legislation. And I know that there's a federal bill as well that hopefully may get passed. There's also a lot of other legislation like the Find It Early Act, and that is supported by Katie Couric, who also had a breast cancer that was not detected on mammogram but was found on a screening ultrasound. Mm-hmm. And so there's a lot of support, or at least potential support, for paying for these additional tests, because what happens is a lot of insurance plans only pay for the mammogram, but then the woman has to pay out of pocket for the ultrasound and the MRI exam. And so they're trying to stipulate that insurance companies have to pay.
And Dr. Daly, any new technologies that you are really excited about?
Well, from a radiation oncology standpoint, I think the new things in breast radiation have included making these schedules of treatment much more convenient for patients. And I think that has been a huge step. So if we go back about 15 years, women with early stage breast cancer tended to come in for 25 to 30 radiation treatments. And those were effective regimens, but that's a big hit on your life, spending 5 to 6 weeks. And for many women who might live far away from a radiation oncology center, that can be a considerable financial hurdle, or even ended up leading to some women not getting radiation that has a known significant benefit in controlling their disease. So these regimens have gradually, through large randomized phase 3 trials, become shorter and shorter. First, there were a number of regimens with roughly 15 give or take fractions that were shown to be completely equivalent to these longer 25 to 30 fraction regimens. And more recently, for well-selected women, we can actually offer 5 fractions, so just a single week of treatment, which really makes this much more accessible for many of our patients. And there's a concept called a boost, where you give a little bit of extra radiation just to the cavity where the tumor was resected. And that always historically was given after the course of full breast radiation, so it added on another roughly 5 treatments. And now that's oftentimes integrated into the course of radiation, so it doesn't involve additional treatments. So all of this has made breast cancer radiation much more accessible. There's also a lot of approaches looking at treating just part of the breast rather than the entire breast for, again, well-selected low-risk women. So some of our patients can have a brief course of just 5 treatments to part of the breast, very minimal toxicity, less financial toxicity, less time commitment, much more accessible. So I think there have been a lot of really nice developments in radiation oncology.
And also avoiding the heart.
Absolutely. Thank you, Dr. Morris, for reminding me. One of the long-term risks that we worry about so much with breast radiation, especially for left-sided tumors, is worrying about dose to the heart, because the heart typically is lying right under the left breast. And there's actually some fairly simple maneuvers that can allow us to avoid the heart. And one very simple one that, again, wasn't done until about 10 years ago was the concept of treating in the prone position or lying on the stomach. And it simply flattens out the rib cage, allows the breast tissue to fall forward, and you can aim at the breast tissue and stay off of the heart. And so it's such a simple thing, but it actually really allows us to minimize dose to the heart and minimize those potential long-term heart complications for our patients.
That's outstanding. Because we're a comprehensive cancer center, we have access to a host of clinical trials from early phase into late phase. Are there trials that are readily available for breast cancer treatment, or is this something that is less prevalent?
There are many clinical trials open at UC Davis for breast cancer treatment. Many of them are in the systemic therapy or drug therapy space, looking at adjuvant therapies, looking at treatments for women with more advanced breast cancers. We do have several trials open in the radiation oncology space as well, actually looking at select women who might be able to omit radiation from their treatment course because they either have particularly low-risk breast cancers or particularly excellent responses to drugs that were given prior to surgery. And I think those are going to be important too, really refining which of our patients are actually really benefiting most from radiation. So we have a lot of trials open kind of across early stage to advanced breast cancer. I'm sure we have some imaging trials open as well.
Yeah, we have some imaging trials for looking at different contrast agents and also for different techniques. And I think the real overarching theme is to de-escalate therapy. We know what has worked in the past, but it's also part of this whole personalization of cancer treatment, because we know some tumors are aggressive, some are less aggressive, and maybe we don't have to treat every patient the same.
And that even starts, like you were talking about at the beginning, from the screening process, personalized screening all the way through treatment. So that's wonderful. Less of a one-size-fits-all and meeting people where they're at and what they need specifically. What kind of advice would you give? I know this is going to sound dumb, but I mean, what kind of advice would you give patients in regards to cancer screenings and then breast cancer screening in particular?
Breast cancer screening saves lives, and you just have to go and do it. I would go to a center where you have the availability of state-of-the-art imaging, and also a facility that if you are diagnosed with breast cancer, you can be treated.
Being a comprehensive, an NCI designated comprehensive cancer center does give women that added access to the latest and greatest treatment. Dr. Daly, you, I know, are constantly looking for ways to improve the care here. I've watched you progress, not just with the clinical trials, but you really put yourself in the shoes of patients and looking for the best ways to get them through this journey. What else should we be doing for patients?
Well, I think care at a comprehensive cancer center encompasses all aspects of treatment, from screening and detecting cancers. And just to echo what Dr. Morris said, screening is so exceptionally important, because I can't tell you how many patients I've seen come in who had their cancer detected at an early stage because they were getting regular screenings. But then care at a comprehensive cancer center involves hopefully cutting edge treatment, access to clinical trials, access to all the supportive care measures, the dietitians, the management of side effects, the long-term surveillance, the top-of-the-line imaging available to help screen for any recurrences. So we're trying to stay on top of all aspects of care, from the screening to the long-term survivorship.
Well, thanks for joining us today, Dr. Daly, Dr. Morris. We appreciate your time. And thank you for tuning in and listening today. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.